Hi, Dr. Garima here again, and we will resume our March 2025 ADC Part 1 questions which were asked in the exam. Last time we had solved a couple of them, and now we are going to solve two questions because the third question then would be a series of the same questions. So these two questions itself will take around 5 to 8 minutes, and I think that's a good span of a video for you to watch for today. So anyways, let's just start. A 42-year-old female patient presents with a medical history of Hashimoto's thyroiditis. It's basically hypothyroidism. For placement of a single dental implant in the mandibular premolar region. Okay. She's euthyroid. Euthyroid means it's a well-controlled thyroid status. And it is stable on levothyroxine. So she's taking some thyroid medication. And she's stable on it, and the thyroid at the present is well controlled and behaving as a normal thyroid. Which of the following local anesthetic strategies is most appropriate for this patient? Most appropriate. By now, if you have seen at least 3 or 4 of my videos, you know when I say most appropriate means all of them are correct. Kind of. Or can be. But you have to choose the most appropriate option. So what is the correct answer? Okay, let's see the options. Lignocaine with 1:80,000 adrenaline, no precautions needed. See, first things with a thyroid patient, see, if it's a normal hypothyroid, you can still go ahead and give adrenaline. If the patient is stable and taking the medicines properly and you got a clearance from the GP. But if there is something like an autoimmune disease affecting the thyroid, there is something called as a hypothyroid which just happens sometimes due to age, but there is no particular autoimmune disease that is happening beneath it. Okay, now that kind of thyroid, like I mentioned, you can treat those patients as normal patients if they are taking the thyroid medication properly. Now there is certain other kind of hypothyroid which is because of an autoimmune disease, like the thyroid was normal and then there is an autoimmune disease which is affecting the thyroid, thereby leading to less production of the thyroid hormone. Now in that scenario, you have put the patient on a medication to control the adverse effect of that autoimmune disease. So that disease is still persistent, it's not gone away. You are just managing the symptoms, because currently the only thing that is affected because of the disease is thyroid and nothing else. That's why the patient is also stable and normal. You get my point? So in such patients where there is an autoimmune disorder present and the patient is taking medication, you generally avoid vasoconstrictors. Okay, so that's the thing. We'll come to the explanation later on, but this is me just giving you a gist of it. So if you're sitting with your notebook, write this point. A normal patient with hypothyroidism due to just aging issues or has been by birth with no other underlying sublying disease, and if that patient is taking proper thyroid medication, treat that patient as normal. You can give that patient adrenaline. But if a patient with an autoimmune disorder comes, and though his thyroid is normal because he's taking medication, the autoimmune disease is also present simultaneously, and though it's not causing any other problem, but it's still there. In such patients, I'm not saying it's contraindicated to give vasoconstrictors, but you would in general avoid, just to not take any risks. You understand? So option A, if they would have mentioned plain lignocaine, I would have chosen that option. But because they mentioned 1:80,000 adrenaline, I'm not going to choose that option. Mepivacaine 3% without adrenaline. Yes, it's not like I like mepivacaine, it just says without adrenaline. Prilocaine with felipressin. Okay. Prilocaine with felipressin you can use in pregnant patients. And this would be your ADC part 2, one of the skilled OSCE stations. They'll have a chart mentioned that the patient is pregnant. You have to extract a central incisor and they will be like, show us how would you do it. And when you'll go to pick up the cartridge to put it up in your syringe, there would be lignocaine, there would be plain lignocaine, there would be with adrenaline lignocaine, Septanest, and then there would be felipressin with prilocaine. You're going to choose prilocaine with felipressin. Remember this, okay? Anyways, so in this patient, can you use that? See, felipressin is also a vasoconstrictor, so I'm not going to choose that. Articaine with 1:100,000 adrenaline and bupivacaine with 1:200,000 adrenaline. Anything with any vasoconstrictor, I'm not going to choose it. So if you know that you have to just choose an option which does not involve any vasoconstrictor, then go ahead and directly choose the answer of mepivacaine. Correct? Now, explanation. Hashimoto's thyroiditis is an autoimmune hypothyroid condition. If well controlled, that is euthyroid, dental procedures can usually proceed without major modifications. However, exogenous adrenaline, that is exogenous means coming from outside the body, can exacerbate cardiac sensitivity in poorly controlled hypothyroid patients due to reduced catecholamine clearance, possibly leading to arrhythmias or hypertensive episodes. Everything is possibly leading, not necessarily. So in general, you have to avoid the epinephrine because of these reasons. Now, even in a controlled hypothyroidism, many clinicians prefer caution. It's not contraindicated with vasoconstrictors. Especially if the procedure is short and effective anesthesia can be achieved without adrenaline. Mepivacaine 3% is a plain anesthetic with mild intrinsic vasoconstrictive properties, making it a safer choice in medically compromised patients, including thyroid disorders. Felipressin containing anesthetics like pralocaine with octopressin or felipressin are generally avoided in hypothyroid patients due to potential vasoconstrictive effects on uterine and coronary vessels. So you're going to avoid that. Now you will say it says potential vasoconstrictive effects on uterine and coronary vessels. Uterine means I'm going to give in pregnant patient. Yes, still it's better than adrenaline. So that is the, one second, I will just on this. Yeah. So that is the answer here. A plain anesthetic agent without any vasoconstrictor, that is what you're going to give. Correct? Now we are going to go ahead with the second question. A 42-year-old female, let me just put this question here, yeah, with Hashimoto's thyroiditis is scheduled for placement of a single dental implant in the mandibular premolar region. Now you have already scheduled the patient. The surgical procedure is anticipated to be routine and uneventful with no grafting. So simple, straightforward procedure. Probably have a stent with you, so all you have to do is just drill inside. She has no allergies, which is the most appropriate approach regarding antibiotic use in this case. So it's basically around the same patient and she's stable. You have to put an implant. So are you going to give antibiotic in this case? Most appropriate approach, okay? So option A, prescribe amoxicillin 500 milligram thrice a day for 5 days post-operatively. Second is you give 2 gram amoxicillin 1 hour pre-operatively. No antibiotics are needed as there is no indication for prophylaxis. Delay the procedure until the patient is off levothyroxine. No, the patient is not going to be off levothyroxine. It's an autoimmune disease. It's not going to go away. He's continuing levothyroxine for a long time. Prescribe metronidazole post-operatively due to systemic condition. Okay, firstly, there is no systemic condition that is happening. And so option E is out of the window. Option D is not going to happen. Option A and B. Now, whenever you give a prophylaxis, it's very, very rare that you're going to ask the patient to continue some antibiotic for 5 days post-operatively. So I'm going to throw that option also out of the window. Option 2 and option 3, like option B and option C, you can be confused with. Administering 2 gram amoxicillin 1 hour preoperatively as prophylaxis is the standard way you give a prophylaxis. But does this condition require that? No, it doesn't. It's not a cardiac condition. It's nothing like an uncontrolled diabetes leading to infection. This condition nowhere is causing infection anywhere in the body. So why am I going to give the antibiotics? You may argue that surgical therapeutic antibiotic should be given, but there is still no infection. It is not a third molar extraction which is going to require a lot of stitches or it's going to go for a long time. It's a simple, straightforward, routine, uneventful procedure without any grafting. When the question is specifically mentioning that, treat the patient like a normal patient. don't give a vasoconstrictor, don't give a block in implant. You anyways don't give a block during the implant, because you want the patient to have the nerve sensation so that you know if you're placing the implant in the right place. Just no antibiotics. Understood? Now the patient is medically stable and euthyroid, and it's not compromising my immunity in any way. So I'm going to go for a routine implant placement without any antibiotics. Okay? So yeah, more explanation on this, you can read it, and that's about it. Unless there is a risk of infection, there is long-term steroid given to the patient, there is uncontrolled diabetes, or there is some underlying cardiac condition which the question says, then only antibiotic prophylaxis has to be given. Prophylactic antibiotic has to be given. I have made a video on this explaining you all what is prophylactic antibiotic and what is therapeutic antibiotic. Do not get confused. In a normal patient, you can still give a therapeutic antibiotic. Prophylactic antibiotics is usually given when you anticipate a risk of infection due to underlying medical condition, not because of the procedure that you're doing. If you're going to give an antibiotic because of the procedure that you're doing, like a complicated third molar extraction, it's called as a therapeutic antibiotic, not a prophylactic antibiotic. Understood? Prophylactic means preventing an infection. Therapeutic is you're doing a procedure, you anticipate an infection because of the procedure that you're doing, and that's why you're giving the antibiotic. Two completely different things. 1,000 times hundreds of candidates get confused upon this, and then they mark the answer wrong, and then they wonder what happened. This is what happened. You did not read. If it's a normal patient, if the antibiotics is going to give because of the procedure, or if it's a compromised patient and you're giving what kind of antibiotics. Do not get confused between these two terms. Prophylactic antibiotics and therapeutic antibiotics. Understood? So I'm going to stop at that. Tomorrow I will continue with another case scenario which was asked in March 2025 exam. Please read more about these topics, as there is a high percentage of repeat questions from the previous exam which is asked in the next exam. So all the September candidates, take these questions very seriously. So I hope everything is fine, and you can leave your comments below the video. Always happy to read them and to reply to them. Bye bye. Have a nice day.